So the idea here is really to help you prepare to succeed in gastroscopy, and probably the biggest challenge in gastroscopy is during the intubation phase. Before you start, you want to get everything right. So as Raf mentioned, you want to make sure the equipment is working, and we normally do a pre-check where you check the wheels working left and right. Make sure your locks are off because you don't want to increase the force that may occur in the pharyngeal space. And you want to make sure your suction and your air are working, or your CO2. And to do that, we normally dip the endoscope in the water and we blow the bubbles, and then we put some gel on. And in both of those actions, there is fluid in the end of the endoscope, and you've got gel on the tip of the instrument. And as Raf said, during your intubation, that fluid leaves the suction channel and drops into the pharynx, the patient's going to cough. Equally, if there's a big blob of jelly on the end which drops off into the pharynx, you're going to get the same response. So I would encourage you that when you've tested the endoscope, the next thing you do is you just spend about 30 seconds putting your scope down and allowing the fluid to be aspirated or drop out the instrument before you start. And then with your gel, you want a thin smear to allow the gel to lubricate the tip of the instrument to allow the intubation without any of the gel dropping off into the trachea. So that's before you start. Raf's already gone through the acute angulation, so I won't repeat that. He also talked about how you handle the scope, and I will talk about why you have the umbilicus on the inside of your arm during gastroscopy in the next session. But I want to talk about how you set yourself up to intubate the esophagus well. And the first thing to say is that in your gastroscope, in its natural configuration, if you're holding the instrument here, and this is a straight line, when you go tip up, you will see we're in this plane. So it comes directly in a parallel line with the head of your instrument. Now, if you think about how the patient's going to be intubated, they're lying on their left lateral, the head's going to be here, and the plane is going to be horizontal. So in order to get the tip of your instrument in the horizontal plane, you need your instrument horizontal. And if you do that, when you go tip up, the tip will be in the horizontal plane. Now, the issue will be if you start to move, and the first thing people do is they look down, the tip of the instrument will move. If you turn around, the tip of the instrument moves. If you bring the scope together, the tip of the instrument moves. So get yourself into a neutral position. Michele's my stack. And for gastroscopy, you'd be on the other side. And if you want to know why you'd be on the other side, it's because when you're gastroscoping, you're eventually getting in the duodenum, which David will show, and you're going to be in this position. And if the umbilicus is on the other side, you're going to confine yourself. So you want your umbilicus on the right-hand side. You want to hold your instrument like this. You want to check your angulation, and then you want to grab it so it doesn't move. So I can then move the head, but the tip doesn't change from the horizontal plane. Where do I grab it?
Basically, you make sure that you, in this case, we have an intubated patient, so this is quite easy for me. But you make sure that you have the scope aligned with the bending and the curvature of the throat. And in that mouth and in the throat, we have to overcome several barriers. And some people actually kind of introduce blindly, especially in the old days. This was done with the fingers, and they used 2 fingers to guide the scope. But now we have all the visibility that we need. So you follow the tongue, right? And then you go over the tongue behind the epiglottis, which obviously now is stretched out due to the intubation. And then you appreciate the rhythmoids. And then you need to choose either right or left to dive in. One important thing is, and some people actually I see doing that, is that they start to insufflate and clean the lens while they do this. Well, you don't want to do this in a non-intubated patient because they will start to cough. Instead, you can use the aspiration while you go in to clean the field and also to avoid coughing during the procedure. So we choose the right or the left, and in this case a cap will also help. And again, it's not a blind introduction, so we have to overcome this barrier. And the way to do that is actually like jump as a dolphin over this barrier. This is a concept that I learned from Jack Bergman. So you basically pull the wheel a little bit down, and while you go over it, then you pull the wheel, push the wheel again away, and that's the barrier you have to overcome. Especially in non-intubated patients, this can be very helpful. And as Rose indicated, the cleaning starts immediately. So maybe if I can have the simethicon. So while we are getting into the esophagus, like basically at 25 centimeters usually, I already start cleaning a little bit with simethicon. So this will go into the stomach and helps to dissolve the bubbles already. And then you move further while you make sure obviously not to drown the patient and suffocate. So you apply suction already to make sure that there's no aspiration, especially again in a non-intubated patient. And meanwhile, the inspection already starts. So things you want to look at while you do this is actually friability, because friability is one of the early features, I think, of subtle lesions. If something starts to ooze just by cleaning the mucosa, again, once you've done that, you come back and retroflex and you suction again everything out of the fundus of the stomach while you slowly pull back and you already start the inspection. And again, you keep on insufflating while you do that. And you see that if you wouldn't do that, let's do that again, you would actually kind of deflate the stomach much more quickly. So you see the difference, and that way you would actually maybe already aspirate the mucosa. So this is the trick and easy cleaning. And actually doesn't take that long, as you see. The patient didn't have any simethicon before. In many cases, it literally takes, like in this case, 1 minute. And now I'm talking a lot, so usually it goes even faster. Okay, and then you notice I didn't go to the duodenum yet. So meanwhile, the inspection is already starting. So the 7-minute inspection time that we need for a high-quality endoscopy includes actually this already. So it's not a rush to the duodenum. No, it's first cleaning the stomach, emptying the stomach to avoid aspiration, and then you're ready to go to through the pylorus and then really go into the duodenum. Also here, this is not a rush. Usually I really like to see where I'm going, so especially the cap can be helpful, so it's not just turning the scopes buttons and go to the duodenum. So you follow the folds and you can actually nicely do it almost like in a colonoscopy, that you can see the folds appearing at the 7 o'clock position while you move along. And in this particular case, adding on a cap can actually help you to better visualize also the papilla. So you go to the third part of the duodenum, and that would complete at least the end. And then the inspection starts. And inspection means that you also freeze. We want to have high quality photo documentation, and the only way to get that is that you freeze the images. Otherwise you have blurry pictures. It's not nice to put in a report, but also it allows you to take a step back and look what's on the screen, right? So then you take the picture of the third part of the duodenum. We see if we can visualize the papilla. That went quick, so usually you need to go back. So we can see a small elevation here, could be a Brunner's gland. And then we try once again if we can see. Meanwhile, we've also inspected the bulb, so we can then take a nice picture here as well. Always freeze and take the picture and see one more time if we can. I saw it before, it's very small here. It was there you see there we have the papilla here, right? Which is also normal. And you take a picture of that as well.
So Raf, fantastic, beautiful demonstration. We got a next session is going to focus on duodenum and J maneuver. I wonder if you can focus on, maximizing visualization in the stomach and talking through people, because we saw in the history of this patient's had a neuroendocrine tumor. I think this, or a NET or so. This kind of scares people, I think. Then the patient comes back for repeated surveillance. Maybe you can take the audience through those two aspects and how you do that and how you inspect the stomach where that's been found.
Yeah, absolutely. So the first inspection is in white light, David, and you can appreciate. As you indicated, Roland, this is about the basic stuff. So we're going to start with some very basic tips and tricks. Have some more time now than during my talk later on. And Rose already addressed some important issues. So basically, before you start the endoscopy, you should look at the endoscope. And one basic thing is how to hold the endoscope. When fellows are starting, or even students when we do our summer school, you see they hold